limited, something that maybe Dr. William will be interested in as well with his group.
Okay.
Um,
Can you see
but
my slide
yeah,
now?
Yeah.
Okay. Cancel everything that we said. Let's start over again. Okay. um, okay. So nearly everything we learned about basic hormone replacement for men in medical school was wrong. And the elephant in the room, of course, is cancer, because we've been taught that cancer is what happens, particularly prostate cancer, with male hormones, and of course estrogens are issue with females. So I want to talk about a patient of mine who just called last week. He's 56 years old. He's been on testosterone therapy, a fairly low dose, for about 18 months. He had a lumbar spine accident about a year ago, and about 4 months ago he had a lumbar laminectomy, and it's pretty much failed. He doesn't really work, hasn't worked too well, and he's been fairly sedentary. He calls last week, says he has a superficial phlebitis in his left arm. And of course, the surgeons decided that it was because of the testosterone. Um, so I thought I would point this out as somewhat of a pitfall, because this is what you're going to get. These are all his diagnoses that from his chart. Again, testicular hypofunction. His testosterone level when I first saw him was 198 total, and the free androgen index, we want that to be between 50 and 110, was about 35. His last testosterone level was 712 total, and the free androgen index, we want that to be about between, again, 50 to 110, was approximately 64. So he's pretty well contained. He has a history of hypothyroidism. He's got slightly elevated TPO, thyroid antibodies. He's got chronic sinusitis, and he's had a head injury. That's actually how I think he ended up with us the first time. He's got a C-reactive protein of about 3.6, and his estrogen levels were at 62. Originally, we were decreasing his estrogen levels, but following our protocols here, Dr. Halassa, we've actually been letting them go unless he's got some symptoms of estrogen excess. His vitamin D level started out at 19. Last one was 74. His TPO normal, the scale was 9. It was 36 originally, and we've gotten that down to 16. I use our 62.7 for low IGF-1 growth hormone deficiency. I don't really feel good putting down, the official diagnosis of E23.0, which is hypopituitarism, unless we're using real growth hormone. So we have them on CJC 1295 with ipamorelin, 5 milligrams each, 0.5 cc's, it's about 0.2 cc's 5 nights a week. And he's had some swallowing difficulties also. So, so this is the case. And of course, the knee-jerk reaction that we got was that the phlebitis was due to this testosterone. I'm not sure how you would prove it was or wasn't. I mean, he is sedentary. He is, he's like I said, he's had a failed back surgery, and he's on antiplatelet therapy also. So I just brought that up to bring that, illustrate that these are some of the things that you're going to see. So testosterone, this was the report from Vegan in 2013, came out around Thanksgiving, that said the testosterone in the first 75 days causes blood clots and heart attacks. And this was news to every one of us that had been working with this stuff for 10 and 20 years at that time. And Morgenthaler pretty much shot it out of the water. This is what they reported. This is what they found in their treatments, untreated is in the light. What is going on? The untreated is in the light colors, and the treated patients are in the dark colors. And what they reported was, as you can see, deaths were half in the testosterone treated. Heart attacks were less than 2/3, and strokes were less than half of in the patients that had testosterone versus those that didn't. And they reported, and total was all events 21% in the untreated group, 10% in the treated group. And of course, what they reported was the exact opposite. And that's what got the play. It was misrepresented, by 50% reduction in events versus placebo. But if you put in testosterone and blood clots, this is what'll come up, just so you know that. This is a study done, overall mortality, total testosterone patients were 8.4% in this study versus no testosterone, 19.2% of patients. This was a 5-year retrospective study. The decreased survival rate in patients without adequate testosterone was 2.3-fold those that did take testosterone. Cardiovascular events with risk factors with testosterone was no different than those that were without risk factors. And the IM versus transdermal users, there was no difference also. And the conclusion was testosterone treatment is not associated with any increased risk for incident composite cardiovascular risk, regardless cardiovascular disease or not. Could whoever that is please mute, because it's a little distracting. Okay, testosterone-induced erythropoiesis. Testosterone stimulates erythropoiesis. The male hemoglobins rise 15 to 20% through puberty. Hypogonadal males have a lower hematocrit versus age-matched controls. Testosterone replacement therapy restores hemoglobins to normal. Testosterone increases an average of 7% in 3 months and 10% in 6 months from low levels to adequate levels. Testosterone-induced erythrocytosis. Again, if somebody, whoever that is, if they could mute that. So it's defined as a hemoglobin greater than 18.5 or a hematocrit greater than 52%. Testosterone injections induce erythrocytosis at 43% of patients versus 15% for the transdermal. So if you're concerned about erythrocytosis, the transdermal route is the way to go. And it's dose related also. So we get much lower doses of much lower incidence of erythrocytosis at low doses, and as the doses go higher, we get higher incidence. EPO levels, erythropoietin levels, are high in testosterone-induced erythrocytosis, and elevated hematocrit and hemoglobin hematocrit suppression remains 30% elevated after 6 months after testosterone has begun. Testosterone-induced erythrocytosis does not change white count or platelet count or clotting factors. You can look at a CBC and tell if it's a blood tumor or if it's a testosterone-induced erythrocytosis. So I used to work a lot with, I still do, with VA patients, and every one of them their hematocrit went to 52. We're up higher here in Reno. We're at 4,500 feet at the valley floor, so the hematocrits are higher here than at sea level naturally. But if they got up to 52, they would send them for a bone marrow. And, I kept telling him, you hit your head against the wall. I kept telling him, you don't need a bone marrow. They're taking testosterone. But they got a new, younger endocrinologist now. So he seems to be a little bit more level-headed. So we're getting somewhere with it. So the etiology of this is there's a hormone called hepcidin. And hepcidin levels get suppressed by almost 50%. It's an iron regulatory peptide, and it's inversely related to hemoglobin and hematocrit production. Hepcidin is also impacted by interleukin-6. Testosterone inhibits interleukin-6, which inhibits hepcidin. It suppresses ferritin levels. You get an increase in iron utilization. And just incidentally, hepcidin is also inhibited by high vitamin D. Okay, remedy here for testosterone-induced erythrocytosis. Increased interleukin-6 will increase hepcidin levels. That's a partial remedy for erythrocytosis, but all of these things that you see here. So high intensity interval exercise, coffee. So if you like to drink coffee, if you want to use the standard American diet, that high fat, high sugar diet, chronic insomnia, alcohol. So go crazy, and it'll bring the hematocrit down. Other things are melatonin, and then things like vitamin D, adequate vitamin D, zinc, magnesium, vitamin C, creatine, 5-HTP, grapeseed extract, which is resveratrol, 5-H again, astragalus and reishi mushrooms, and drugs, venlafaxine, Effexor, and fluoxetine. Those of you who have heard me before, venlafaxine is a bear to get off of. I might tell my students if they write for venlafaxine, they fail. It's as bad as addiction as any narcotic. Just as an aside, what is polycythemia vera, which is what the erythrocytosis is confused with? This is a myeloproliferative neoplasm, and is on the rare disease list. I mean, this is something that you don't see every day. It's an increase in red cells, white cells, and platelets. The hemoglobin and hematocrit are the same as the testosterone elevation, but you get a thrombocytosis, a leukocytosis of 12,000 in the white count, 400,000 in the platelets, more than that, and also an elevation of greater than 100 in alkaline phosphatase. This you get an increased blood viscosity, increased risk of blood clots, and the risks of strokes, heart attacks, pulmonary embolism. 97% of these patients have a genetic mutation in the JAK2 or TE2 gene, and the EPO is low. Remember, the EPO in testosterone is high. These are the symptoms of polycythemia vera: fatigue, vertigo, increased sweating, facial redness, pruritus, especially after a shower. You get an increased red cells and mast cells, splenomegaly, gout, and kidney stones. And again, just as a side, phlebotomies are treatment, hydroxyurea, and whatever, I can never pronounce these JAK2 inhibitors. They release the pruritus, antihistamines, hydroxyzine, and there is a burnout phase where the hemoglobins drop down, and then patients need transfusions. This is the difference between polycythemia vera and erythrocytosis. You get an increase in red cells in both. You have genetic markers in polycythemia vera, the JAK2 and TE2 mutations in 97% of the patients. The EPO is low in polycythemia vera and high in erythrocytosis. Blood viscosity is increased in both, but in the testosterone patients, it's the red cells only. And you do get a risk of some fluid overload or hypertension, but in the risks are with polycythemia vera are blood clots, heart attacks, strokes, pulmonary emboli. This is a combination of studies that I put together. So the risk for thromboembolism here or strokes or CVAs here in the general population is 5.3 per thousand, and versus 10 for testosterone. So it's a little bit higher than the general population, but you get 3 times the increased incidence in polycythemia vera. And then heart attacks and blood clots are actually less in testosterone in patients than in the general population. And as you can see, it's very high in the polycythemia vera patients. And if you want to play with statistics, the patient that I showed you, the incidence of blood clots here is 10 per thousand versus 8 per thousand. So if you take 10 minus 8 is 2, the decreased incidence is 20% with the testosterone patients. So the bottom line here is, one, for our patient here. One, it doesn't mean you can't get blood clots. I mean, you certainly can, but the incidence is less than the general population at risk. And two, I'm not sure how you could say it's from testosterone. I'm not saying you can't say it's not from a testosterone, but I'm not sure how you can say it's from that. These are the references for the information I gave you. So let's go back now and talk a little bit about hormones in general, natural versus synthetic, and that's where the cancer issue came from. So bioidentical hormones we define as the exact chemical and cell structure replicas of hormones that we produce by the body. They're usually derived from plants, and they're either from traditional pharmaceutical companies or they are compounding. When we all first started doing this, there might have been estradiol and prometrium, which was the bioidentical progesterone, was released in 1998. Now there's a whole array of them. And I used to go through the AMA's, objections to bioidentical hormones, and there were very few of them, and they weren't tested, and we all know the song and dance. But now, DHEA they actually picked out as one that had little to no use until a pharmaceutical company came out with an FDA approved intravaginal DHEA for vaginal dryness, and then all of a sudden it became okay. So the real problem was the synthetics. Okay, they contain unnatural chemicals. The estrogen and synthetic progestins have a 69% increased risk of developing breast cancer from women who never took any at all. Synthetic Premarin alone, given to older postmenopausal patients, caused a statistically significant increase in heart attacks and strokes. And synthetic progesterone increased breast cancers, heart attacks, and dementia. Why with hormones at all? Again, adequate hormones, patients will live longer. On average, 10 to 15 years if they have adequate estrogen and adequate testosterone levels. From age 60 to 70, they will live 10 to 15 years longer than if they do not. All other factors being discounted. Hormones are antidepressants. They're anti-anxiety agents. They improve mood, strength, energy, clarity, sense of well-being, sexual energy, positive impact on cognitive function. They protect against mitochondrial dysfunction. They control neuronal excitability. They can moderate anorexia nervosa, particularly testosterone. They can control, they're anti-inflammatory. They increase interleukin 10, the inhibitor of pro-inflammatory cytokines. Deficiencies, testosterone levels are inversely related to depression and blood sugar levels and a long-term cognitive function. Testosterone levels in the lowest quartile percentage presage the highest incidence of depression. And specific lab values at 295 total testosterone levels. The patients, males, are at risk for depression, and at a 148 and lower, those patients will be frankly depressed. So you have patients that have depression and they're on all sorts of medications and are not getting anywhere. Make sure that they have testosterone level check. Poor hormone levels result in fatigue, suicide ideation, weak muscles, loss of muscle mass, lack of energy, poor balance, poor mental fatigue, and lack of sexual organs. I'm going to talk a little bit about each one. Again, this is just an overview. I mean, we can do an hour on each topic, but I'm going to give you just an overview here. And I divide the hormones that we look at, there's 10 of them, into 7 major and 3 minor. There's no real reason for that, except it keeps them, it's the way I sort of categorize them. It's my own value. Okay. So again, when we talk about men's health, we're going to be talking about testosterone, correct? So I did this at AMMG, and we started out with progesterone in men. And yes, we do use progesterone for men. We can measure it. And usually what we want to do is if we get any measure at all, that seems to be adequate. So 0.3 to 1.3 micrograms seems to be the right amount. Progesterone aids in testosterone production. Insufficient testosterone can lead to estrogen dominance It improves cognitive performance. It improves mood and stress. It's necessary for adrenal adequacy. It's a positive allosteric modifier of allopregnenolone, which stimulates GABA, which is your calming neurotransmitter. And it's a 5-alpha reductase inhibitor. It can decrease dihydrotestosterone and improve prostate, stroma, and hair follicle viability. Low progesterone in men, like women, they'll exhibit agitation, irritability, can't sleep, poor libido, headaches, short-tempered. Long-term, you might see osteoporosis, muscle loss, infertility, sarcopenia, hair loss, erectile dysfunction, depression, gynecomastia, benign prostatic hypertrophy, and impotence. So sometimes a little bit of progesterone goes a long way. Again, here's the lab values, 0.3 to 1.3 nanograms per milliliter. And the starting dose, we can go anywhere from 5 to 25 milligrams and titrate it up to 200 milligrams to achieve a mid-range of 1.0 nanograms per milliliter. We can add in some DHEA, 25 milligrams, titrate that up to 100 milligrams. Orally, the first one was pregnenolone, sorry, I apologize, sorry. Orally, you can compound testosterone 25 to 50 milligrams and titrate that up to 50 milligrams twice a day. You need to be a little bit careful. That can make the patient sleepy, particularly in the daytime, and they can get some GI or abdominal bloating. Transdermally, 10 to 20 milligram or 1 to 2% cream. They can get this over the counter, put it on the inner wrist or the inner arm, and intranasally, I think we're using a little bit higher doses now, and 25 milligram to even a 50 milligram per ml, one spray, and you can go up to one spray twice a day. You can mix it with oxytocin for libido also. And it works quite nicely as a way to boost testosterone without the reason to not use testosterone is particularly in young men is because of you get sperm decrease with testosterone. This is sort of just the lay of the land here. The hypothalamus is stimulated by the gonadotropin releasing hormone to stimulate the anterior pituitary gland to produce luteinizing hormone and the follicular stimulating hormone. Luteinizing hormone stimulates the Leydig cells to make testosterone, and the follicular stimulating hormone stimulates the Sertoli cells to make sperm. The way to remember it, to keep it in mind, when you're looking at an LH and FSH, L is for Leydig cells, is testosterone. FSH, S is for Sertoli cells for sperm. There's an inhibin hormone, which gives you a negative feedback. And when you get an adequate amount of testosterone, you'll get another negative feedback to the hypothalamus. 95% of the testosterone is made in the Leydig cells. The importance of testosterone in men and women is in the brain. It increases libido, mood, cognitive function, ambition, drive. In the heart, it reduces the risk of heart disease, raises HDL. Liver, again, whoever's there, could you please mute? Liver, it synthesizes serum proteins. Again, sexual organs, sexual function. Bone marrow stimulates stem cells. Bone increases bone density, and kidneys, it stimulates erythropoietin, and a muscle, it increases muscle strength. Testosterone sufficiency in men decreases dry eye syndrome, LDL cholesterol, fibromyalgia, arthritis. It improves skin turgor. It improves sexual performance, clotting factors, bone density, again, as we mentioned, joint pain, inflammatory cytokines, LDL cholesterol, and sarcopenia. The controversies, we already talked about the erythrocytosis. The other one, the other big one is prostate cancer and benign prostatic hypertrophy. This is just a summary of a talk we gave, and we showed specifically the studies here. I have the references here. If you want them, you can get them yourself, or I can send you the specific studies. But this was our conclusions here. Again, we're just doing an overview. High testosterone levels does not increase the risk of prostate cancer. Testosterone therapy does not increase the risk of prostate cancer. It doesn't increase the risk of progression in men, and testosterone therapy in metastatic disease does not cause rapid progression and death. This is what to do with patient with prostate cancer. If they had a radical prostatectomy, when the PSA is undetectable, less than 0.1, usually about 3 months post-op, we can, again, use low-level testosterone. For X-ray therapy, radiation, you can, again, begin at 3 months when it's low. Active surveillance, which is basically not doing anything, just following the PSAs. You will get a rise in the PSA, and you can begin immediately. If there's a recurrence post-op, metastasis will recur with or without testosterone therapy. The PSA will rise. You just need to be a little bit careful. You need to pick your patients. And again, erythrocytosis. These were the conclusions. We already went through this. High levels do not increase the risk of blood tumors, cardiovascular disease, strokes, or blood clots. Other complications: gynecomastia is a benign proliferation of glandular tissue of the breasts in males. Etiology: aromatization of testosterone is estrogen greater than androgen imbalance. Usually will show up at 4 to 8 months if unregulated in patients that are vulnerable. What to do about it? Lifestyle, so alcohol, caffeine, weight loss. Without erectile dysfunction, progesterone 100 milligrams at bedtime with some DIM, progesterone cream to the breast tissue. With erectile dysfunction, we use the anastrozole, we use the estrogen blockers, again, 3 times a week, just until the gynecomastia is under control. DIM will control estrogen dominance at 100 to 200 milligrams. I don't have on here calcium D-glucurate, 250 milligrams, especially if they have GI symptoms, will also control estrogen excess. You can decrease the testosterone dose. You can compound a DHT cream, 2.5%, but progesterone 5% cream, you can get that over the counter. And sulforaphane or broccoli extract at 0.1 to 0.5 grams per kilogram is also a good way to control the excess estrogen. There's been a whole a cadre of lectures over the past 3 to 5 years about not blocking estradiol. Aromatase inhibitors, basically will give you the symptoms of low estrogen. So osteoporosis and fractures, if done for a long period of time, flushing and sweating, hot flashes, night sweats, body aches, numbness, tingling, cold feeling in your hands and feet. For men, we use very low doses, but it can happen. Trouble sleeping, depression, mood changes, high blood pressure, and even strokes. Osteoporosis, fatigue, mood swings, depression, heart disease, decreased libido. Estrogen for men, it protects against heart disease. It protects against respiratory distress if the levels are high or low. The liver is the primary site of estrogen metabolism. The kidneys maintain the phosphorus calcium metabolism, and the estrogen's nephrotoxic. Skin, it maintains turgor and hyaluronic acid. It inhibits sexual activity and spontaneous erections if the estrogen's too high or too low. Low estrogen, you get benign prostatic hypertrophy with an estrogen-androgen imbalance. It protects the GI tract from irritable bowel disease and ischemic bowel disease, and it protects the upper GI from ulcers, gastroesophageal reflux, and visceral fat. So what I do now, just anybody is interested, and everybody has their own protocol. So at the moment, we monitor the estradiol levels. We don't treat them unless the patients have one of several symptoms of estrogen excess. So gynecomastia, breast tenderness, breast sensitivity, breast cysts. If they have emotional lability, we will lower estrogen levels. Some patients, when the estrogen levels are high, have better libido and better sexual function, and some of them they're actually worse. So if the patients are having erectile dysfunction and their estradiol levels are 60, 70, 80, we will lower it to the 20s and 30s. If they don't have any of those symptoms, we leave it alone. That's sort of what I've come to conclude over the past couple of years with this controversy. Testicular atrophy, again, so when the estradiol levels are 20 to 28, you'll have an adequate FSH, and you'll get adequate sperm production. You'll get an 85 to 90% testicular activity. When the estradiol levels are higher, you're going to get a decrease in FSH. And as we know, you get testicular atrophy and you get decreased sperm count. You get a decreased testicular volume. So high dose testosterone theoretically can act as a contraceptive. So testosterone, 250 milligrams IM every 4 days. Theoretically, I don't know if I'd hang my hat on that, should act as a contraceptive. So what to do for testicular atrophy? Again, lifestyle, alcohol, caffeine, weight loss, you wear loose-fitting underwear. Don't you put your phone on your lap. Don't put your computers on your lap. And the remedies are the same. So without erectile dysfunction, progesterone 100 milligrams at bedtime, DIM 100 milligrams also at bedtime. And if they have GI symptoms, I don't have it on here, calcium D-glucarate, 250 milligrams twice a day. If they have erectile dysfunction, you can use an anastrozole, 0.25 milligrams, 1 to 3 times a week with some DIM. HCG is 100 to 300 units sub-Q daily, or 500 to 750 units. This is the one I do twice a week. And again, reduce the testosterone levels. So that's testicular atrophy. To improve fertility, converting IM testosterone to transdermal testosterone and maximum of 0.5 to 3/4 gram a day will improve fertility. Again, the same doses for HCG. This is not the testosterone, to raise testosterone on its own. This is using it with testosterone, the HCG. There's a synthetic HCG called Ovetrel, 0.2 cc's per day. Zinc, 50 milligrams per day. Vitamin A, vitamin E, increase protein. And unfortunately, for those of you that are vegetarian, you need animal-based protein, plant-based proteins, decrease testosterone. And again, lifestyle, exercise, stop smoking. And those that have too much exercise, the over-exercisers, will also end up with some fertility issues. What test to use? Total testosterone versus free testosterone versus bioidentical testosterone. Also, you can do salivary tests, you can do urine tests. The best test in the morning for total testosterone is AM before 10 a.m. Most of the insurance companies want 2 of them. I'm not sure why. Normal, depending on what lab you look at. So there's one major lab in town here. It's 250 to 1100. There's another one that's 264 to 916, I think. And quite frankly, our goal is we get adequate testosterone levels. We get good levels with minimal and no side effects at 700 to 900 total, and 2 to 4% on the free. Most of the labs will calculate a free testosterone, but I don't find that those are very accurate. We actually calculate the free androgen index. You can also do the bioavailable testosterone. I think I have a slide on free androgen index. I'll tell you what that is in a minute. You do a semen analysis and an FSH if there's fertility issues, a DEXA scan if they have chronic hypogonadism or if you suspect osteoporosis. If the testosterone level is less than 150, you need to check prolactin levels. Quite frankly, we do this on all our patients. At least once we check prolactin levels. And again, then chromosomal studies for pubertal males with very low testosterone levels. So the free androgen index is what I like to use. It's easy to calculate. You take the total testosterone and divide that by the product of 0.288 times the sex hormone binding globulin. That product. That's the denominator. Total testosterone is the numerator. 30 to 130 is normal. 50 to 110 is our optimal for males, and it's about 2 to 4 for females is the optimal. These are different testosterone replacements. I took out the commercial names because we did do this for a CME, and I guess we can get CME for this. So clomiphene is not available commercially anymore. The generic makers went out of business after COVID. So Clomid is the trade name, and it's very expensive. It's $15 to $20 a pill. We get it compounded, and we get it for about $2 a pill, and we get it from a compounding pharmacy in Florida. And when we shut this off, I can tell you which one it is. So we can get 30 pills for about $60 and a little bit of shipping. And patients are usually do it anywhere from two to 4 times per week. The next four are synthetic products. Some of them are patches, some of them are pumps. I don't use them at all. I have 3 patients on synthetic products. I have over 1,000 male patients active in my practice. I have 3, and they're all doctors. So that should tell you something. Testosterone, cypionate or ethanate, anywhere from 40 to 100 milligrams per week. The 1 cc, 200 milligram is you're basically overdosing your patients on that. It's really too much. Males need about 10 milligrams per testosterone per day. So that's about 70. You can go up to 70 to 80 per week. That's physiologic. Females, it's 1 milligram per day, or about it's 1 to 3 milligrams per day, or anywhere from 7 to 20 milligrams per week. Testosterone pellets, there's a number of ways to calculate it. We do it on weight, and I have a table for that. Again, that's a little bit deeper than I want to go into here today. We want to do just kind of an overview. There are trochets that can be compounded. There is an oral pill now that came out, testosterone undecanoate, but it's extremely expensive, and it's kind of not practical. There's also a testosterone injectable undecanoate, which is basically 5 times a year after a loading dose. But again, there's a complication of an oil embolism. Patients have to stay in your office for 30 minutes to an hour to make sure they don't have blood clots after these injections of this stuff. And they're about $800 a dose. So they're, again, kind of impractical. You can use ATG if we can find it. The FDA sort of ripped it out from the compounding pharmacies. It's a pro-hormone. It creates an anabolic state. It balances catabolic activity. It increases testosterone. It will preserve the testicular size and sperm count. We can use it in low doses to preserve testicular size in patients that are on testosterone. It can also promote weight loss. We used it for a long time as a weight loss adjunct until the compounding pharmacists couldn't make it anymore. It will decrease insulin resistance scores, triglycerides, and fat waist to hip ratio. Increases fat-free mass, and unchanged are C-reactive protein or inflammatory markers and homocysteine and lipids. Here are the doses for HCG for testicular volume or semen volume: 250 units sub-Q, day 6 to 7 after, if it's a once a week injection, or we do it on the same day after getting a twice a week injection. As a proxy for testosterone, you need much higher doses. We start with 3,000 units every 2 weeks, and we expect a 25% increase in testosterone, or 1,000 to 1,500 IUs twice weekly sub-Q. It's pretty expensive. The alternative is clomiphene, and the HCG, it can develop antibodies if you use it too often. So you would use it 2 months on and 1 month off. The clomiphene, like I said, we can get 30 pills for about $65 with shipping. And if you're going to use two to three a week, and it's a lot less expensive. These are herbal remedies, and these are ways to raise testosterone without using testosterone. High intensity interval training, high protein fat, healthy fat, animal fat diet. Unfortunately, the plant-based foods don't raise testosterone levels. Stress reduction techniques. Adequate vitamin D. We get our vitamin D levels 50 to 80. Normal the labs say 30 to 100. We like a goal of 50 to 80. Adequate sleep. So to reduce sex hormone binding globulin, the protein that testosterone travels with in the bloodstream to get to its end organ tissues is sex hormone binding globulin. If that is extremely high, you're going to have less free testosterone. Boron, we start at 3 milligrams a day. Use it at bedtime, go up to 9 milligrams. Will decrease sex hormone binding globulin usually by about 30 to 40% within about 2 to 3 months. Magnesium, 10 milligrams per kilogram, will increase free and total testosterone. DHEA, as you know, is a precursor, 50 to 100 milligrams for males, 10 to 25 milligrams for females. Ashwagandha, make sure you check your ashwagandha, the doses. You need enough ashwagandha. 300 milligrams twice a day is the minimum. It will increase LH, FSH, and TSH. It boosts the anabolic process, but you need enough. Most of the supplements don't have enough in it. So they say, well, it didn't work. It didn't work because there wasn't enough in it. Mucuna pruriens will improve testosterone, LH, and also some of the neurotransmitters. It's good for the sperm count and motility. It will decrease prolactin and FSH. Tongat Ali, I put in here because it's in a lot of supplements. I've never really had a lot of good success with it. Myomin is a Chinese herb that we like. We've used this quite often. It acts as an aromatase inhibitor, and it will raise testosterone levels. Zinc increases testosterone levels at an adequate dose. So remember, for estrogen, you need 30 to 50 milligrams to raise estrogen levels. To raise testosterone levels, you need about 250 milligrams. So the dose matters. Pure pomegranate juice and pumpkin seeds can raise testosterone levels. Chrysin is an aromatase inhibitor and an anti-inflammatory. Shatavardi is an Ayurvedic herb. Increases testosterone. Maca, we use a lot, 3 grams a day, will increase libido and improve erectile dysfunction. And selenium with N-acetylcysteine increases testosterone and sperm counts. So here's 20 ways to raise testosterone levels without using testosterone. This is just a chart, so you may get lost in the weeds. So I made this chart, and it has the remedies that you can use with the doses. And then here's the rest of them. And here's the references for all of that. Any questions? Or keep going? Okay.
Keep going.
Okay. Anybody there? Okay.
Yeah.
Growth.
Quick question, Dr. Bill, quick question. Did you say dim is best at bedtime?
Yeah. Mm-hmm.
Okay.
Yeah. Okay. So growth hormone. Growth hormone is 191 amino acid polymer. They're specific amino acids linked in a specific manner in a specific order. And I'm showing you a Lego car and a Lego windmill. So if you buy a box of Legos that has this car picture on the cover and you follow the directions exactly, you'll end up with this car. And what peptides are, just going to segue here, peptides are pieces of growth hormone. So they're pieces of this car. So we can get some of the characteristics of the car. So let's say you want a cart. We can get the base, the sides, and the wheels without the top, and you're not going to use as many Legos. You can make a tower out of it. You can make all sorts of things out of it, not using all the Legos, and that's what the peptides are. Growth hormone itself stimulates growth and cell reproduction. Growth hormone enhances memory, concentration, mental clarity, the main thing, besides energy, strength, and sense of well-being, the main point I want you to get here is that adequate growth hormone signifies adequate, what is known as executive function. Executive function is the ability to get things done. It's the ability to start projects easily, finish projects easily, multitask easily, and have enough energy to get the tasks done. That's where growth hormone really shines. And low growth hormone is an inability to plan, dark moods, inability to switch between tasks, poor concentration. Growth hormone is converted to IGF-1, insulin growth factor 1 in the liver. Insulin growth factor 1 is necessary for growth hormone to be effective. And without insulin growth factor 1, you can have all the growth hormone you want, and you're not going to get those effects. Now, interestingly, autistic children have very high growth hormone levels, and so they have big heads and big bodies, but they have very low IGF-1 levels. There's a disconnect in the conversion in the liver between growth hormone and IGF-1, and this is where the behavioral issues come from, and a lot of the brain development, cognitive function, blood sugar issues with these kids. And blood sugar and the ability to sort of control themselves. I don't know if you've dealt with autistic children, they get out of control rather easily. So a couple of controversies with growth hormone, and again, you need adequate IGF-1 for growth hormone to be effective. So growth hormone levels, the highest growth hormone levels are in the or IGF-1 levels for weight control are those that have adequate IGF-1 levels. So adequate IGF-1 levels, the better BMI, less abdominal fat. As you go down towards the right, the lowest quartile of IGF-1 levels, these are your increased risks of obesity. You'll see the same pattern in cardiovascular risk here. So highest levels of IGF-1, the least cardiovascular risk and carotid artery intimal thickness, and then the lowest quartiles, the highest incidence of growth hormone, lowest quartile, the highest incidence of carotid artery and coronary artery disease. And then controversially, cancer. So cancer, we figure growth hormone levels, adequate growth hormone will increase cancer, but apparently it's the exact opposite, at least according to this study here. The highest growth hormone IGF-1 levels have the least amount of cancer and less metastasis, and the lower growth hormone levels have the higher levels of cancer and the metastasis. Growth hormone stimulates thyroid activity and also stimulates androgen activity. Head injuries. Growth hormone is the first hormone that is dissipated in growth hormone in traumatic brain injury. Acute injuries incidence is a rate of 20% after 96 hours after a traumatic brain injury. And 12 months later, if untreated or unrecognized, 35 to 40% of survivors of traumatic brain injuries, and these are mild traumatic brain injuries, these are no loss of consciousness, will have growth hormone deficiencies. And again, so you'll see personality changes. You'll see things, again, the inability to perform tasks, the inability to start or finish tasks, the inability to multitask, and a lot of obsessive compulsive tendencies. There's a lot of depression again and fatigue with head injuries, and so the number one hormone that is affected in head injuries is growth hormone, and number two is testosterone. Side effects of growth hormone, think of the mnemonic page, so paresthesias, so pins and needles in the hands and feet, arthralgias, joint pain, blood sugar, insulin issues, insulin resistance, and edema. So page, these are the side effects. Lab values, We measure IGF-1 in everybody. So growth hormone levels themselves are sort of volatile. They're difficult to get. The test has to be done quickly after the lab is drawn. The technician has to not shake the tube. The levels quite frequently are inaccurate. So this is from Dr. Gordon. He likes growth hormone, IGF-1, and IGF-BP3. We use the IGF-1. It's a little bit more stable. We like to see it at the 200 to 250 nanograms per milliliter. That's usually where we like to see our patients. You can do, if you're going to treat patients with growth hormone, technically you need to do a stimulation test. You can do McCarran as an oral test now. So the gold standard is still the insulin tolerance test. But you can get hypoglycemia with it, so it's fraught with some, there's some issues with it. So McCarran is an oral synthetic peptide that's approved for growth hormone stimulation test. So after our lab evaluation, usually what we'll look at is either peptides or secretagogues for 3 months. Then we'll retest them if they have if the IGF-1 levels are elevated. We'll continue it for another 6 months to a year, and then discontinue it. We'll retest it. If they're not increased, we'll use a peptide, a growth hormone releasing hormone, and a growth hormone releasing peptide. We like CJC 1295 with ipamorelin. You can use hexamorelin. I think that's the one. If patients have lipodystrophy. And we also have been using CJC 1295 with drug affinity complex now. That's a once a week shot instead of an everyday shot. The patients come to the office for that. If there's no change, you need to do one of the stimulation tests, and that's when you can consider HGH. Growth hormone is by the FDA is illegal for anti-aging, so you need to keep that in mind. Thyroid. Thyroid function. Thyroid is your gas pedal. It tells your body how fast or how slow to go. And we need an adequate amount of thyroid, but not too much, not too little. Symptoms, 98% of the time, patients will present with hypothyroidism when they do present this way, and they have dry skin, dry hair, fingernails crack and break, constipation, can't lose weight, cold all the time, tired all day long. The opposite for hyperthyroid, they get hair loss, bulging eyes, sweating, diarrhea, weight loss, frequent bowel movements, soft nails, and warm. Hypothyroid patients, their body temperature never goes above 97.6 if they're truly hypothyroid. Hyperthyroid patients, the patient's body temperature never goes below 99.2. This is just an overview. This is a quick fix. Diet, gluten-free, dairy-free, low carbohydrate, and sugar also would count there. The thyroid medications, we'll use a T3, T4 combination, T4 only, which is, what the endocrinologists tell us is the only way to go. We'll sometimes use T3 only, and we'll use combinations that are off the standard route. We use a lot of T3, T4 combinations. We use the desiccated thyroid extracts also, and I use them in older patients. I don't have any problem with them. We get nasty letters, but I don't really care. We let the patients know that that's not quote unquote the standard of care, and if they get any palpitations, to let us know. I rarely see that at all. I mean, if I see one or two a year, that's a lot. The microbiome is important in thyroid because 80% of the thyroid of the immune system is in the GI tract, specifically the small intestine. And depending on who you read, the etiology of thyroid disease now is anywhere from 50 to 90% is the immune system. Traditionally, the powers that be ignore the immune system altogether. They tell you, one, it doesn't really matter, and two, there's nothing you can do about it, and that's just patently false. We get patients better all the time. We use plant sterolins. I'll give you the trade names when the CME credit is over. Plant sterolins act like Pac-Man in the patient's system. They're anti-inflammatory, and they actually surround the antibodies like phagocytosis and eliminate them. They don't work that quickly, though. You can get a decrease in the TPO thyroid antibodies by about 50% in a year. We also will use selenium, 200 micrograms per day. Selenium can decrease the thyroid antibodies by about 40 up to 40% on its own. With the plant sterolins, we usually can get up to a 90% decrease in the thyroid antibodies. The better the antibody control, the better your patients will feel. We also use low-dose naltrexone. We never use in immune thyroid disease more than 3.0 milligrams per year. For your reference, the prescription dose is 50.0 milligrams. We never use more than 3.0 milligrams per day, rather. Sorry. The thyroid is extremely sensitive to the naltrexone. The patient's thyroid function will improve. Rarely, but once in a while, the patients won't need their thyroid medication anymore, and a lot of times will show up hypothyroid or hyperthyroid because they're taking the same thyroid doses, and the naltrexone has improved thyroid function. Naltrexone takes a little bit of time to work. If the patient tells you I took it for 2 weeks and it didn't do anything, you're not going to get anywhere. You need to give it at least 4 to 6 months. And this can be a game changer for a lot of patients. What I don't have on here is iodine. So I do have it in here, I think, iodine. So iodine's becoming, again, one of those things that was taboo for years and years and years. It's becoming a staple now. I've been reading Brownstein and watching his videos and our own, Stefan Hartman. And so when we're looking at patients with thyroid symptoms that are not quite ready for thyroid medication, we'll use an iodine selenium combination. And we'll use up to 12.5 milligrams of iodine. We'll start at 3 milligrams. We use the iodoral solution and then take it up to 12.5 milligrams. Dr. Brownstein will go to 50 to 100 milligrams at times. I've not gone that high yet, but I anticipate that I will. 200 micrograms of selenium. And we get a lot of patients, we save them from even having to need thyroid medication. Iodine, as you know, is inversely, iodine levels are inversely related to incidences of breast cancer and prostate issues. And so we're making a dent on those also. Again, so this is the schematic for our conventional versus integrative thyroid model. The etiology, we look at things like gluten, different toxins, particularly heavy metals, lead, cadmium, arsenic, mercury, and I always forget one. There's another one. Then somebody chime in. Lead, arsenic, cadmium, mercury, and aluminum. That's the other one. Those are the major ones. Infectious diseases, the number one is Epstein-Barr. Patients, these kids get mono in their late teens and early 20s, and 10 years later, they end up with autoimmune issues, particularly autoimmune thyroid disease. H. pylori, we like that one. If you find somebody with H. pylori and they have positive antibodies, go back and retreat the H. pylori, and on occasion, probably maybe 5% of the time, the thyroid disease will go away. It doesn't happen often. Don't promise anything, but I have seen the autoimmune thyroid disease, quote unquote, cured in a small number of patients, and it's only been men, unfortunately. So I've not done it in females at all. Hepatitis, herpes, Lyme disease, and Yersinia food poisoning are the other biggies as far as infectious diseases as an etiology for our autoimmune issues. HPA axis insufficiency, so cortisol abnormalities can trigger autoimmune disease. Iodine again, and certain medications, so beta blockers, synthetic progesterone, progestins, and birth control pills, and amiodarone. Oral amiodarone is notorious for that. Looks like the same thing. So we talked about this. I went backwards. Okay. How to lower thyroid antibodies naturally. Sugar-free, gluten-free diet, anti-inflammatory diet. You want to make sure you have an adequate vitamin D level. Moducare is our plant sterolin, 2 to 3 a day. It will balance Th1 and Th2 cytokines. It will decrease thyroid antibodies by up to 50% a year. Another is systemic enzyme is wobazyme N. There's lots of wobazymes. You want to use N, 3 caps twice a day. Selenium, 200 micrograms per day, can decrease thyroid antibodies by up to 40% within 90 days, and you'll get an improved conversion of T4 to T3. N-acetylcysteine is a free radical scavenger, an antioxidant, a liver detox agent, and it protects the liver from all sorts of toxic issues, and it generates it's your precursor of glutathione. Ashwagandha, again, in an adequate dose, at least 300 milligrams twice a day, inhibits NF-kappa beta, acts as a prebiotic, as a neuroprotective, as an anti-inflammatory, antioxidant, and it will stimulate testosterone production also. B vitamins, particularly B12 and folic acid, are inversely related to thyroid antibody load. So patients with high antibodies, they're going to have low B12 and folic acid. Vitamin D, we like 50,000, the weekly dose here, the time release dose here. That seems to work quite well. Zinc, again, this is a different dose, 30 to 50 milligrams. Low zinc levels are seen with hypothyroidism. Low zinc zinc inhibits Th17 immune lymphocytes. Low zinc equals increased oxidative stress and inflammation. Patients need adequate iron. We measure a ferritin level here. We want the ferritin level to be between 90 and 110. I use iron glycinate now. I don't use ferrous sulfate or ferrous gluconate. Iron glycinate, 28 I think it's 28 micrograms per day, will give you an adequate iron levels and iron stores. Curcumin is an anti-inflammatory antioxidant. It creates apoptosis, angiogenesis. It detoxifies heavy metals. Magnesium is usually severely low. Magnesium levels are associated with increased thyroid antibodies, but not TPO. Probiotics, spore-based probiotics reduce thyroid antibodies. And now we're looking at the postbiotics. I'm not sure what the effect of the postbiotics are with the thyroid antibodies, but I'll report back when I have an answer. Black currant seed oil, we use this as a substitute for when we couldn't get ivermectin or hydroxychloroquine during the COVID years. Black currant seed oil will decrease TPOs by up to 50%. You need 2 grams per day. We like the liquid form of this. Inositol, you want to use Myo and Cairo inositol. It will improve thyroid antibodies. It will reduce TSH. It will, especially when combined with selenium, and it will reduce TPO, thyroglobulin. And in females, it will regulate the menstrual cycle, and it will decrease. It will help with the polycystic ovarian syndrome. Iodine supplementation is now, according to Brownstein, low iodine.
He's back. You got to unmute yourself, Clearfield.
What happened?
You went away. We were here.
All right. I'm not sure what happened.
You're still muted?
No, I'm not muted, right? You can hear me?
Yeah, you're back.
Okay. Where did I go away? Do you remember?
You need to go back a couple of slides.
Did we do how to lower thyroid antibodies?
Yes.
Okay. Did we
You
get
did that.
we did that? Okay, that's where it went off. Okay. You got black currant seed. You got black currant seed oil and inositol?
No, you were on inositol.
Okay. So myo-cairo-inositol combination will with selenium will reduce TSH and improve free T3 and reduce thyroid antibodies. 600 milligrams of myo-inositol, 200 micrograms of selenium twice a day. The myo-inositol we like is a powdered form. I'll give you the brand names later. Iodine reduction. According to Brownstein, low iodine levels are a cause of autoimmune thyroiditis, and he treats them accordingly. So he's doing now, the last I heard, spot urine levels. He's not doing the 24-hour urine levels, more for a convenience. And if the iodine levels are low, he'll supplement them. Omega-3 fatty acids will also decrease thyroid antibodies by up to 30%, and we use a combination of all of these things. There's the chart on that, and here's the references for that. How we doing on time? Doing okay? Keep going. So cortisol, stress hormone.
We're good on time. Keep going.
Produced in the adrenal glands. This is responsible for your fight or flight. Major functions include circadian rhythm, aids in fat metabolism, reduces bone formation, decreases amino acid uptake, increases sodium and water retention. Insulin, it's an insulin antagonist, and it has some effects on fertility, and it's an immune suppressant. Functions of cortisol, throughout the whole body. It maintains the circadian rhythm. It helps with mood. It's an anti-inflammatory. It's an insulin antagonist. It influences the DHEA insulin ratio. It helps with bone remodeling. It affects fertility, weight control. It aids in fat metabolism, stimulates glucose and glycogen turnover, and it decreases amino acid uptake. It's inversely related to DHEA levels. So high cortisol, low DHEA. One of the first remedies should be DHEA. High cortisol diminishes every major hormone, all of them that you see here. But testosterone, estrogen, and progesterone will raise cortisol levels. All of the rest of them will lower cortisol levels. So high cortisol will diminish all of the hormones. But when we treat patients with testosterone, estrogens, or progesterone, you'll get an increase in cortisol and a decrease in cortisol with all the rest. Does that make sense? So in the extremes, there's Cushing's disease, which is very low cortisol levels, Cushing's disease, very high cortisol levels, low potassium, a big body, and Addison's disease, low cortisol levels, high potassium, and the body is frail. What we deal with most, we don't usually deal with this a whole lot, at least in our practice. What we deal with is Mr. In Between. And so, of course, the endocrinologists say it doesn't exist. So this is what Dr. Wilson termed as adrenal fatigue. It's, sometimes it's high cortisol levels, sometimes it's low cortisol levels, but it's not at the extremes of either Cushing's or Addison's. Primary symptoms are the patients are fatigued in the morning, they have difficulty staying awake, and they need some stimulant mid-morning. In the afternoon, they feel like they need a nap. By the dinner hour, they're exhausted. But later at night, 8 o'clock, 9 o'clock, 10 o'clock, they get a second wind, and then they have trouble sleeping. There's usually sugar or salt cravings with this, and there's usually poor concentration and brain fog. If you ask patients these questions, you will get positive answers. I see this probably at least in a third of the patients who come in for whatever. Most of them don't know what an adrenal fatigue is. So call it what you want, and call it, it's sort of an in-between, but this does exist. And the protocols that we've come up with are quite effective. Physical diagnosis. So you can get a postural hypotension, have the patients drink 8 ounces of water. You have to wait a half hour, have them lie down for 5 minutes, and they should get they should get an increase in systolic pressure by 10 to 20 millimeters. If it falls, that's an indication that they have this adrenal fatigue. Iris and pupil contraction. So the inability to hold a contraction when a light is shine in their eye, not into the eye, but across the eye. Normally the pupil will contract for 20 seconds. If the pupil wavers and between dilated and contracted, or it initially contracts and then dilates within 2 minutes, regardless of if the light's shining on it, and lasts for 30 to 45 seconds, that's positive. Sargent's white line is a line from the pubic symphysis to the umbilicus. I use the back of a reflex hammer and just draw a line right down that line. Rather than turning red as it should, it doesn't turn any color at all, or even lighten up. And you'll see this in about 25 to 40% of the patients. Between the iris and the Sargent's white line, that's a pretty good physical diagnostic characteristics. Waist to hip ratio, males should be greater than, if they're greater than 0.9, and females greater than 0.8, from the umbilicus to the widest point of the hips. Rogoff's sign is you press on the adrenals, and you get pain or tenderness when the adrenals are pressed. Paradiagnosis is pain and pressure when palpating around the navel at 4 and 8 o'clock, and at the angles of the bottom of the ribs, and you get pain and pressure there. That's a positive sign of an adrenal interaction. Rapid pulse in Japanese acupuncture, rapid pulse is 90 beats per minute or greater. So a rapid pulse of 90 beats or greater per minute are another sign. Slow, thready pulse indicates as excess energy is turned into a deficiency. And here are the references for all of those things. A little word on reverse T3. So a normal T3, a reverse T3 develops 90 to 95% of the time when there's a cortisol abnormality. I use reverse T3 as my proxy for those saliva tests that are expensive. We still do them, but we don't do nearly as many as we used to, because I found this to be quite accurate. Normal is about 9 to 25. When the patients are over 15, they have all of those symptoms that I mentioned, which are when they wake up in the morning, they're tired. In the middle of the morning, they need something to keep them going. In the afternoon, they need a nap. By dinner time, they're exhausted. Later at night, they get a second wind, and there's usually sugar or salt cravings with it. So we want the free T3 less than 15, or you can see a free T3, reverse T3. Free T3, and I multiply it by 10 just for convenience, divided by reverse T3. You want that to be greater than 2.0. If it's less than 2.0, it's usually, again, a cortisol abnormality. This is a normal saliva test. So this is your cortisol awakening response. You get a lot of cortisol early in the morning, and then it falls off by noon and sort of meanders on down. And this is what it should look like. DHEA, like I mentioned before, is inversely related to cortisol, and they have opposing effects on the immune system. You'll sometimes see a DHEA cortisol ratio, or it'll be read as a cortisol DHEA ratio. So DHEA to cortisol, or the opposite. So when it's, I had it there, sorry. When it's the cortisol to DHEA ratio, we want it to be at least 5 to 1. If it's cortisol to DHEA, it's 0.105. And then you can do it in the saliva also. Okay. The ratio is decreased in stressful situations, chronic inflammatory diseases, migraine headaches, anytime you're going to have, a cortisol abnormality. So what to do about it? Lifestyle changes, so anti-inflammatory diet, stress reduction techniques. The second wave is adaptogenic herbs. I should have DHEA in here also. Again, 10 to 25 milligrams for females, 50 to 100 for males. The adaptogenic herbs, this is the core, ashwagandha, rhodiola, and cordyceps. Whichever brand you like. There's lots of pharmaceutical grade supplement companies that make this, but it should have those three herbal remedies as the core. Next, if that's not adequate enough, we add in adrenal extracts, and then lastly we'll go to Cortef, so hydrocortisone. and they come 5 and 10 milligrams. We use 1.5 milligrams in the AM, 1.5 pills in the AM, or 7.5 milligrams, 5 milligrams at noon, 2.5 milligrams before 6 p.m. You should have minimal to no steroid side effects as long as you keep the hydrocortisone less than 30 milligrams per day. Okay, it's not like prednisone at all. Insulin. So insulin regulates glucose production. It counters the actions of adrenaline. It converts glucose into triglycerides. It maintains glucose levels at a steady rate. It plays a significant role in serotonin production, and it enhances muscle development. Insulin dysfunction. So not enough insulin. You're going to have bone loss, depression, excessive thirst, excessive urination. Insulin resistance. Insulin is ineffective. Sweating, chills, clamminess. Too much insulin, you're going to have breast issues, aging, acne, irritable bowel syndrome, migraines, weight gain, infertility, and insomnia. Your calculation for insulin resistance is fasting blood sugar times fasting insulin. And to get the units even, you're going to divide it by 405. A normal insulin resistance is less than 2.9, and an optimal is less than 1.9. And these are the remedies that we use to improve insulin sensitivity and to improve blood sugar control. We like berberine a lot, and we use high doses. We use 400 to 800 milligrams twice a day. We also use those doses for our weight control. This is not so much for weight loss, but we use berberine with resveratrol at about 100 milligrams at these doses. We use this for after our weight programs are finished. This will help keep the weight from the patients from regaining the weight, which is always a complaint. Chromium picolinate, 600 to 1200 micrograms per day. And we have some combinations of berberine and chromium together. Alpha lipoic acid, we'll use that for peripheral neuropathy with berberine for blood sugar control. Zinc and conjugated linoleic acid, 1 to 3,000 milligrams per day. Taurine is another way to control blood sugars. Biotin, particularly if they have hair loss. Vanadium. What I don't have on here is Gymnea sylvestre, which is our sweet tooth killer that we go to, which works quite nicely. And again, adequate vitamin D. Metformin, is your first prescription go-to. Here's a couple of other things: N-acetylcysteine, GABA, and then some foods: lentils, chickpeas, fenugreek, and cinnamon. There's the Gymnea sylvestre. We use that as a sweet tooth killer. Myo-inositol, I mentioned that earlier. Myo-inositol, D-chiroinositol improves insulin resistance and hyperandrogenism. So remember, those are two of the hallmarks of polycystic ovaries. It also induces ovulation in polycystic ovaries and restores ovulation. It's quite good at sort of smoothing out all of the rough edges in patients with polycystic ovaries. DHEA, again, one of the precursors of androgen precursors. Think of it as a mini testosterone, improves sense of well-being, bone density, insulin resistance, myelin sheath production. It helps with allergy symptoms, immune function. It counterbalances cortisol, and it improves growth hormone levels, especially at night. It decreases visceral and subacute fat. It reduces LDL and cholesterol and triglycerides. And in 1952, it was actually FDA approved as an antidepressant. High DHEA levels are neuroprotective. Low DHEA levels and DHEAS, so sulfated DHEA, not just DHEA, due to stress and aging, lead to cognitive decline. And so I just mentioned this as just another issue. DHEA dysfunction with deficiencies, you're going to have noise intolerance. Next one I'm going to do is pregnenolone. You're going to have light intolerance. So I use LP as my mnemonic there to remember that. And other than that, we already mentioned that pregnenolone is again the mother hormone, or maybe the grandmother hormone. I think it's the mother hormone. It comes from converted from cholesterol. when you think of pregnenolone, think of memory. Inadequate pregnenolone, poor memory. We measure pregnenolone levels on all of our patients. 90 to 110 is our go-to level. When they're low, we'll replace it. It's pretty inexpensive. You can get 90 pills, 100 milligrams of pregnenolone for about $15. It's pretty inexpensive. Like I said, it's a GABA receptor antagonist that stimulates the excitation and inhibition of the nervous system. It acts as an anti-inflammatory. The deficiency results in a 100-fold drop in inhibiting GABA synaptic mechanisms, and adequate pregnenolone ensures adequate neurotransmission. Lack of pregnenolone results in anxiety, panic attacks, agitation, aggression, insomnia, and social phobias. And we mentioned that all those over on the right. We'll see low pregnenolone levels with short-term memory loss, forgetfulness, depression, insomnia, and some autoimmune diseases. I don't see excess or high pregnenolone levels unless we're treating patients with pregnenolone and we overshoot the mark a little bit. They'll get some fluid retention, muscle aches, and kind of feel uptight. This is the steroidogenic pathway that we talked about a lot. This is the way we look at it mostly here. So cholesterol to pregnenolone to DHEA to androstenedione. Testosterone will convert to dihydrotestosterone from 5-alpha reductase. But the point here is that pregnenolone will convert to progesterone, which will convert to 5-alpha dihydroprogesterone. So notice progesterone, dihydroprogesterone, testosterone, dihydrotestosterone with the same enzyme, 5-alpha reductase. If you use a 5-alpha reductase inhibitor, you're going to get some blockage of this pathway here. This leads to allopregnenolone, which stimulates GABA to produce your GABA calming neurotransmitter. And those who there's a small segment of patients who take 5-alpha reductase inhibitors, finasteride and dutasteride, that end up with severe and sometimes permanent mental maladies, leading all the way up to suicide. From taking some of them, they've only taken one pill, and they get this 5-alpha reductase blockage, and it's extremely difficult to overcome. So if you're prescribing finasteride for hair loss in young guys, those are the ones that are most vulnerable to this. So please read up on it, and maybe Dr. Halassa, we can do I have a whole hour and a half on post-finasteride syndrome. These are the mental and psychological effects from blocking the progesterone to dihydroprogesterone. So what you're doing is you're setting aside that the neurosteroid pathway, and the progesterone, like I said, converts to dihydroprogesterone through 5-alpha reductase. So, young guy, a 20-year-old guy who wants to is losing his hair, and he suddenly becomes impotent, and he's got priapus that can happen from the 5-alpha reductase inhibitors, and he's got severe mental issues. And last I looked, and it's been a little while, 127 suicides have been traced to taking 5-alpha reductase inhibitors. And the incidence of mental diseases is listed as about 1%, which does, us doctors slough it off. Well, 1% is not much. In 2019, the last statistics that I looked at, there were 11 million prescriptions for 5-alpha reductase inhibitors. 1% of them is 110,000. So that's a lot of you're going to see these people somewhere along the line. This is the pathway from cholesterol to pregnenolone to progesterone. This is the pathway that gets blocked. And these are the symptoms. Again, anxiety, memory loss, slow thoughts, mood changes, decreased comprehension, PTSD, apathy, insomnia, and all the way up to suicide. 5-alpha reductase inhibitors decrease allopregnenolone, which diminish GABA. Decreased GABA symptoms are, as you can see here on the left, memory loss, slow thought process, impulse aggression, anxiety, depression, suicide ideation, insomnia, and you can see there's a lot of the same things with the post-finasteride syndrome symptoms. They're pretty much line up pretty much the same. Here's some more symptoms of low GABA, and so be careful of that. This is just a schematic of that. And again, we'll get this to Shell or Dr. Halas if anybody wants this. Here's the schematic of that. I'm almost done. Prolactin. Increased dopamine will decrease prolactin levels in brain damage, particularly in autism and traumatic brain injury. And you're going to end up with edginess, agitation, aggressiveness, anxiety, fidgetiness, and these are these are the patients that have so-called treatment-resistant anxiety and depression. And this could be just from a mild traumatic brain injury. It doesn't have to be, somebody that's been in a coma for 6 months. They could have bumped their head, or they got hit in the face with a volleyball, playing volleyball. And we had a young girl in high school, straight A student, and she was she was on a volleyball team, and the ball got spiked. It hit her right in the center of the forehead, and she was stunned and sort of disoriented for maybe 15 minutes, and then snapped out of it. And then 2 weeks later, she was having trouble seeing and reading, and she went on to all sorts of antisocial behaviors. And got STDs and became pregnant and got into fights and broke another kid's jaw with a lock and ended up going to juvenile hall. And she went from a straight A student going to college and never been in trouble at all to an antisocial.
I think you lost him again. Same thing happened last time.
You lost me again? I hear you guys. Damn internet. Are you on? Yeah? Are you off?
Yeah.
I'm back.
You're back.
Sorry, I don't know. I'm not doing anything. It's my system. So sorry. Am I muted? Yeah, I'm not muted. Okay.
No, you're good.
All right. Where did I lose you this time? Prolactin?
You were giving us the anecdote about that prolactin autistic girl. What was the deal with her?
No,
The girl that got hit playing volleyball.
So this was a girl who was playing volleyball. She was a straight A student, cheerleader, all-American girl. Got hit in the head with a volleyball. Got spiked, and just kind of sort of a bell rung, and she stumbled around for 15, 20 minutes, and then she seemed to be okay. And then 2 weeks later, she was having trouble reading, and then she started having all sorts of bizarre behaviors, and she became agitated and aggressive, and she ended up started drinking, and then she ended up pregnant. And she ended up with STDs, and then she was getting in fights, and she ended up in juvenile hall. And she broke some other girls in a high school girl with jaw.
What was the cause of all this?
Well, she started with she got hit in the face with a volleyball, and she had a traumatic brain injury that wasn't recognized. Okay.
TBI.
She had she was depressed, and she had suicidal, and they were giving her SSRIs and the atypical medications, and what her prolactin levels were 3. So we got them back up to where they should be, like 11 or 12, and we straightened out the rest of her hormones. And she straightened herself out, and she's down at the Florida International University now. She's in a marine biology program. So I know that's not easy. So
hey, can I add a little something here that you may have said? We know that a lot of people that get the traumatic brain injury will also concuss or contuse their pituitary.
Right.
It lives in that little bony cella turcica.
Right.
And with that brain sloshing forward, it pulls the stem, and they'll thump their pituitary. We see a lot of this stuff, but interesting, that was only 2 weeks. Mostly it's like 6 or 8 months. We'll start to see.
So we have a lot of head injury patients, and I do have a talk on that also. You'll see prolactin level changes within 24 hours of a traumatic brain injury. and you'll see profound levels change within 96 hours. So I didn't put that again. I've tried to do an overview. I couldn't put everything in here. But
Were you able to get her off of the SSRIs?
Oh yeah. We did. So we did. We basically gave her a high dose pregnenolone, progesterone, and GABA, and that snapped her out of it. And the SSRIs did nothing. And that pretty much snapped her out of it. This is for high. Yeah, this is for high prolactin levels. You know, the medications, bromocriptine and cabergoline. You can use some anti-inflammatories, curcumin, mecunopurines. L-theanine is good for if they're agitated, and again zinc and chasteberry. Now chasteberry you need to be a little bit careful with. Low dose chasteberry, 100 to 120 milligrams twice a day, will raise prolactin levels. High doses at 480 milligrams will lower prolactin levels. Okay, and chasteberry decreases interleukin 6. Lab studies. How are we doing here? We're doing okay. This is our workup here. And again, you guys need it. I can send it to you. This is our. These are the labs. These are the serum labs that we do. So C-reactive protein. We want our C-reactive protein normal 0 to 3.0. We want it to be less than 1.0. Our remedies here are usually omega-3 fatty acids and curcumin. For blood sugars, and I tell the patients, you know, it's like the Christmas Carol, you know, the ghost of past, present, and future. So the blood sugar of the past, I liken that to hemoglobin A1C. Again, the standard less than 5.7. Fasting blood sugar 65 to 84. That's our ideal. Every point over 84, there's a 4% chance of developing a blood sugar abnormality within the next 5 to 10 years. So a normal blood sugar, say, is 94 or is 84. Or patients' fasting blood sugar is 94, minus 84 is 10 times 4. That's a 40% chance of developing some sort of blood sugar abnormality within the next 5 to 10 years with a fasting blood sugar of 94, which is considered normal. Insulin, normal is 2.6 to about 25. We want it less than 5. I told you how to do the insulin resistance calculation. We want that to be less than 1.9. Homocysteine is a measure of B complex or folic acid deficiency. It is produced with damaged arteries, particularly coronary arteries, and it's increased with elevated with blood clots, strokes, heart attacks, and diminished circulation. Normal homocysteine, we like it less than 11. Our optimal is less than 10. Our go-to here is methylated B6, B12, and folic acid. When somebody comes in and they have a homocysteine level of greater than 15, that's a cardiac problem until we rule out otherwise. And we do either send them to a cardiologist or we start the cardiac workup and send them back to their regular doctor first. Vitamin D, our optimal is 50 to 80. That's where we want it. Estrogens, we measure estrone and estradiol. Estrone, that's your cancer-causing pathway. We want that less than 100. Anything over 100, we'll treat the patients. We'll give them 7 keto DHEA, 25 to 100 milligrams, and that usually will decrease the estrone by anywhere from 20 to 40% within about 6 to 8 weeks. Estradiol, that's your female characteristics: skin, hair, nails, voice. The male estradiol, we talked a little bit about that. This slide's a little bit outdated. Female estradiol, we do a calculation. We do estrone plus estradiol divided by progesterone. Anything less than 250 there, we don't worry about the units on that one. They're usually balanced and the patients feel pretty good. Progesterone, that's again second half of your cycle. Here's those calculations that I told you about. Low progesterone patients have agitation, irritability, can't sleep, poor libido, headaches, short-tempered. We want the estradiol divided by progesterone to be less than 250. Early in our career, and I still calculate it just because out of habit, we do a progesterone estradiol ratio. We didn't have estrone. We have to multiply the progesterone by 1,000 to get the units correct. Our goal is 100 to 500. If it's less than 100, they're estrogen dominant. If they're greater than 500, they're progesterone dominant. Testosterone, again, our adequate levels are 7 to 900 total, and 50 to 110 on the free androgen index. I have the calculation here. I did tell you about it. Total female at one lab, 2 to 45. That's kind of useless. Our optimal is 30 to 40 there, and 2 to 4 on the free androgen index for females. DHEA, again, precursors of it's not a precursor with pregnenolone for the androgens and estrogens. It's the counterbalance to cortisol. We only use it for 6 months to a year if the patients are on testosterone. I find that we get sort of a negative feedback, and we give them more DHEA after they've been on adequate testosterone, and it pretty much has no place to go. So it's in my view, it's kind of useless after about a year. I know there's some characteristics to it that are probably positive, but we've been able to sort of stop using it if they've been on testosterone for greater than a year. Pregnenolone, the grandmother hormone, is for memory and cognitive performance. 90 to 110 nanograms per deciliter is our go-to there. Hematocrit in Reno, again, we're 4,500 feet here, so 40 to 50 is actually considered normal in our world. Females 35 to 45. I don't get too excited, even with a hematocrit of 55%. If the patients say they'll tell you that they're heavy, they feel heavy. So we do a phlebotomy and they feel a lot lighter. But there's no real urgency in it. As long as their white counts and platelets are normal, it's not a blood tumor, and you're not going to see increased incidence of blood clots. We look at the MCV, the mean corpuscular volume, on the CBC. Normal is usually about 79 to 97. If it's greater than 97, it's pernicious anemia. If it's less than 80, it's an iron deficiency anemia. Prolactin, we told you about that. If it's very high, it's pituitary adenoma, or they're breastfeeding. If it's very low, it's that treatment-resistant anxiety and depression. IGF-1, we want that to be between 200 and 250. And the thyroid, the TSH, our goal is about 0.8 to 2.0. The free T3, we want it in the upper third, about 3.4 to 4.2. Free T4, I'm not too fussy about that. 0.8 to 1.2, 1.4. I don't worry too much about that. The reverse T3, we want that under 15. You can get what's called the low T3 syndrome. The thyroid antibodies, we talked about those. At TSI, if they're hyperthyroid. Ferritin levels, so that's iron store, we want that to be 90 to 110, and B12 and folic acid levels, we want them in the upper third also. So you want B12 at least about 7 to 800. Folic acid, you want that about at least 4 to 5. Advanced lab tests that you can do, especially for immune diseases, and again, these are whole other topics. So an IgG food not allergy, food sensitivity test, it should say. A functional GI test, there's lots of companies that do that. We look at the microbiome there, and we get digestive products. SIBO for small intestinal bacterial overgrowth. Lyme antibodies. We do mold testing a lot now. I'm getting pretty good at picking those out. Thank you, Dr. Campbell. The food sensitivity test. Okay, this is what you need to ask. Here's your history. For estrogen, hot flashes, night sweats, brain fog, belly fat, memory loss, bone loss. For estrogen excess, estrogen causes cysts. The affected organs, the breast, the uterus, and the ovaries, and gallstones. So ovarian cyst, breast tenderness, fibrocystic breast disease, breast tumors, uterine cyst, which we call fibroids, endometrial cyst, we call endometriosis, and gallstones, particularly if the estrone is elevated. Anxiety, infertility, joint pain, and weight gain. That's estrogen excess. Progesterone, agitation, irritability, can't sleep, poor libido, headaches, short-tempered. For testosterone, anxiety, depression, poor sense of well-being, poor muscle tone, urinary incontinence, vaginal dryness, poor libido, and poor sexual function. Too much testosterone, oily skin, oily hair, acne, skin breakouts, particularly on the neck and shoulders, quote-unquote road rage, which quite frankly, I don't see very often, higher blood pressures. Long-term, you can get some atherosclerotic vascular disease and swelling of the hands and feet. Thyroid, dry skin, dry hair, fingernails crack and break, constipation, can't lose weight, cold all the time, tired all day long. Cortisol, tired upon rising. They need a stimulant mid-morning. They need a nap in the afternoon. They're exhausted by dinner time. They get a second wind, and that's when they do their best work, and they're wide awake. But after 8 p.m., there's usually sugar or salt cravings. They nod off easily when they sit still. Growth hormone is for strength, energy, sense of well-being, multitasking, starting projects, finishing projects, memory, concentration, sometimes dark moods, and obsessive compulsive diseases. For excess insulin, thirst, excess urination, abdominal pain, not enough insulin, sweating, tired, hunger, and easily shakeable. DHEA is sort of like testosterone. Pregnenolone is for memory and stress intolerance. Low prolactin is anxiety and depression. High prolactin, unexplained headaches, balance issues, irregular or no menses, galactorrhea. You need to look at the pituitary adenoma. Here's a chart. It has doses, treatment doses. Functions are in the center. Signs and symptom deficiencies are on the right for all the hormones that I talked about. And then here are the references for everything I talked about. And I'm going to brag a little bit. Where I live, there's a magazine called Best of Sierra. I don't know if I've showed you this before. I won't show it to you too often. But the Best of Sierra, we were voted best men's health, best weight loss center. We were second in women's health and in overall medical practice. So I don't usually brag too much. You can tell the AOA to go kick rocks, right? Okay, how was that?
Excellent.
Great.
Okay, you got any questions?
Yeah, that thing about the gallbladder, I've always wondered, why do these young women get these gallbladders removed? Do you really think it's the estrogen dominance issue?
Yeah, they've been on birth control pills since they were 12, right? They get their first period, they get a cramp. Mom takes them to the doctor who gives them birth control pills. They're on birth control pills till they get married, and then they have babies, and then they get put back on birth control pills. And now, so synthetic estrogen, and if they're lucky, it's just a synthetic progesterone, and they're doomed from the start. Usually, what you'll see is that they'll come in their late 30s, early 40s, and they have irregular periods. And they'll say to me, "Oh, I had my gallbladder out when I was 30." I mean, right. That's typical. Okay.
What did they teach us in PA school? They said, "Oh, look for the fat female 40. They're gonna get their gallbladder out." They didn't tell us it was because of estrogen, but it makes sense because the progesterone is going to be declining.
They probably didn't know.
No,
but
it makes sense. The progesterone declines. They're going to get the estrogen dominance at age 40, of course.
Right. Mm-hmm. And remember, when you go through perimenopause, estrogen levels are really at their highest. They go all over the place. You get a 26% surge in estrogen in the perimenopausal period. So, do I have that right, Carol? Yeah. Okay. So,
one question about labs. I'm noticing that the ranges are being changed by many labs. For instance, if you take vitamin D, many of them have different ranges. If you take thyroid, they have different ranges. I mean, so iron, for instance, ferritin, if you look at, many of them have different ranges. So how do we reconcile all of these different ranges that they're having out there?
I think you have to go by whatever the reference range is for your lab, and then narrow it down from there. So what we'll do is we'll take the reference. Let's say the reference range for vitamin D is 30 to 100. Okay, so what we'll do is we'll add the two together. It's 130 and divide by 2. That's 65. Then what we'll do is so remember what those numbers are for the most part. It's 2 standard deviations. It's 95.4% of whatever you're measuring. Unless it's been changed because we want to sell you cholesterol drugs or something. I don't know. You younger guys, do you know what when I had the same color hair as Stefan? Do you know what the top normal cholesterol was?
No.
Standard deviation. You know what it was? 350.
Oh, wow.
That was normal, right, Carol? Yeah, 350 was normal. Don't show up at 350 today. So what we do is 30 to 100. I'm going to use vitamin D. So that's your two standard deviations. Find the midpoint. 30 and 100, add them together is 130, divide by 2 is 65. Then what we're going to do is we're going to take one standard deviation, which is 68.145, something like that percent. So we're going to break that in half, 34% on either side of our midpoint. For this example, 0.34 times 65 is 15. So we're going to take 15 off of our 65, that's 50. We're going to add 15 to our 65, that's 80. So that's our range, 50 to 80. So Dr. Tano, that's what we do. Okay, find the range, whatever, because I mean, in our town here, like for the thyroid antibodies, now when it's zero to a number, I do it a little differently. But for thyroid antibodies, there's two major labs in town here. One, the TPO normal is 0 to 34, and the other one is 0 to 9. So we obviously, the one that's 0 to 9, if you're getting 18, that's not normal. If you're getting it at 34, that is normal. Unless you read somebody, I think it's Isabella Wentz says if it's over 2, it's positive no matter what. I'm not quite on board with that, but that's the way to do it. You have to look at whatever, you have to go by what the calibration is of whatever instruments you're using.
Yeah, because of these discrepancies, actually the primary care physicians, many of them who are not well versed, I think they're misdirecting the patients. When someone has a vitamin D level of 70 or 80, they say, "Whoa, you're gonna die," and then they start stopping the vitamin D.
Yeah, well,
that's really tragic. But I don't know how we can convince them or get them to learn this, so then they don't cause harm.
The way we've been doing it, 10 years ago, if you said vitamin D, everybody was screaming. Vitamin D, you're going to kill them. You can't give them vitamin D. That's awful. Did I ever tell you about my patient Tom, who did himself in with vitamin D? So Tom was 44 years old. This was about 1990, 91. Now you have to remember, we didn't measure vitamin D levels then. It wasn't even on our radar. And Tom was a terrible diabetic. He was 44 years old. He had a half a foot off. I think he had only 7 fingers left. He had stents in he'd had 2 MIs. He had stents in his coronary arteries. He had a stent in his carotid artery. He wasn't in great shape to begin with. So one night, it was in the winter, and this is Northeast Pennsylvania, where it's picture Chicago in the mountains. I mean, that's the kind of weather it is. It was an ice storm. I get a call from the ER that Tom's in the ER and he's having seizures, and he's never had seizures before. And he'd been there an hour, and they were giving him the maximum doses of the anti-seizure medication, and it wasn't touching him. It wasn't stopping it. So the only thing that was off, his calcium level was 15. So, calcium level of 15 with seizures, with no other reason, that's a brain tumor until you rule out otherwise. Well, he didn't have a brain tumor. In fact, he had no tumors. We couldn't figure out what the hell was the matter with him. I had the neurologist there. I had an endocrine guy there. I had a neurosurgeon there. I had a cardiologist there. He's in the ICU. He's seizing away. Nothing's touching him, and nothing's stopping it, except I put an acupuncture needle at CV26, and that stopped it for about an hour. And then one of the specialists came in and said, "What the hell is this?" And he ripped it away, and it started again. But that's another story. So I called his wife. We were in Northeast Pennsylvania. We don't like people passing away on us if we can ship them someplace else, which then was either NYU or University of Pennsylvania Hospital down in Philadelphia, which is about 150 miles away. But with the way the weather was, nothing was moving. So I called his wife and I said, well, we don't really know what's wrong with him. And she says to me, "I don't know if this matters or not." So I have to tell you 2 pieces of information for it to make sense. So a year before Tom showed up in our in the hospital, Sam's Club had opened in our town. And it was a big deal. You could buy 14 rolls of paper towels for $6, but it was the big scandal was you had to pay. It was $10 for the membership at that time, and someone's tried to run them out of town. But anyway, so Sam's Club had opened, The second thing that you need to know is that in Northeast Pennsylvania, it's an Eastern European ethnic community. It's where all the coal miners came from Poland and Slovakia and Romania and whatnot. And one of the traditions that came with the those who came over was that mom puts a candy dish at the stairwell, so and fills it with candy. And remember, it was the low fat, no fat era, 1990, 91. So, avocados were no good, but M&Ms and Reese's Pieces, hey, no problem. Go for it. There's no fat in those, right? So mom would put Reese's Pieces and M&Ms and Kit Kats and whatnot in a glass bowl at the stairwell. And every house there, even though it was coal country, had a basement, a first floor, and a second floor. So there was a candy dish, in each one. So she tells me that he went to Sam's Club 6 months before he showed up here and bought 6 bottles of vitamin D. Now, a bottle of vitamin D at Sam's Club is 1,000 pills. And he emptied the candy dishes and put the vitamin D in the candy dishes because he heard vitamin D was good for him. So, and she says, oh, and by the way, he went back last month and got 3 more bottles and there's only 1 left. So he took 8,000 vitamin D pills, and I don't know what the dose was. If I estimate it was probably a 2,000 unit pill. So at that rate, he took 8,000 pills in 6 months. I figured it out. That would be 88,000 units a day for 6 months he took.
Wow.
So I called the lab and I said, can you guys run vitamin D wasn't on our, nobody did vitamin D levels. So I said, can you do a vitamin D level? And I got yelled at. Do you remember Statler and Waldorf from the Muppets? That's who runs the labs in places like that. 2 old guys who don't want to do anything. They drink coffee and tell war stories. And the war was World War II, so, or maybe even World War One. So eventually we got a vitamin D level. He said all I can do. This is all I can do. It was greater than 900.
Holy cow!
Yeah, yeah, and he never woke up. He passed away, but he did it to him. And let's face it, he earned it. If you date somebody who takes a little bit too much vitamin D, I had somebody came in today, it was 135, and they were a little bit dizzy, and if they felt like ringing in their ear, we can fix that. That's not so terrible. But greater than 900, God knows what it was.
Wow.
And if it was, I don't even know. It might have been a 5,000 unit pill, so it would have been 3 times as much. So
is the average vitamin?
That's the story of Tom.
Yeah, that's nice. The average vitamin D level. The average daily vitamin D intake, is it 8,000 or 5,000? Because a lot of times
I go by. So for every 1,000 units of vitamin D, that the blood level should go up by about 8 points. It takes about 8 to 12 weeks. So if you have a vitamin D level of 30, and we want to get to the midpoint of 65, 1,000 units. If you do 2,000 units, that's 2 times 8 is 16. That'll get us to 46. 4,000 units, 4 times 8 is 32. That's 62. 5,000 units, 5 times 8 is 40. And 30 is 70. So 4 to 5,000 units is the right amount. If it's wintertime, I'll go higher. If it's summertime, I'll go a little bit lower. Sometimes we'll use, especially if we have to use a lot, we'll do the 50,000 once a week one. That seems to work pretty well. The real problem is the patients don't forget to take it. But that's the way to figure it out. 1,000 units per 8 points. Okay.
So can we do 35 IU per pound?
I don't know. I've never done it that way. You tell me.
Yeah. I think it's 35 IU per pound. So then for children, we can actually calculate how much we need.
35 IUs per pound. I'll figure that out, for the next time.
Yes.
Okay. But I've done this for a long time. 1,000 units per 8 points. Okay. So we go by the labs, right? And we rarely have an issue with that. So
the other question I have is when we have excess insulin, then we have breast cancers and all of that.
Mm-hmm.
Is it because when we have too much estrogen excess, especially with xenoestrogen, they tend to increase the insulin level? So maybe with breast cancer, and uterine cancer and female cancers with a high insulin is too much xenoestrogens and other estrogens.
Well, certainly that's an issue. Is there you would know better than is there labs for the the xenoestrogens and all and the environmental
the only thing that some people have attempted to measure is glyphosate, but I don't know any other like your PCBs and dioxins and all these other things if anybody is measuring them. Phthalates.
Yeah, I'm not really. I'd have to ask that. Maybe Dr. Patel would know. I don't know. I'm not sure about that.
Repeat put out that prolactin was a better measure of estrogen status if it was elevated, that you want to be around 8 or so.
Mm-hmm.
And if you have elevations above that, start thinking excess estrogen activity and low thyroid.
Yeah, that's correct. Actually, I know that. Yes.
Okay. So as you all can see, it takes a little bit of time, but to connect the dots, it's actually quite fun, as I think anyway. It's fun for me anyway. So is there anything in the chat? I see there's a few things. Is there any questions here? Optimal level for pregnenolone is 90 to 110. Oh yeah, okay.
Yeah, I got all those. Thanks.
I
got all my questions answered.
Okay, you did. Okay.
Dr. Clearfield, I thought you said at one point if pregnenolone was under 200, you treated.
No.
And today you said
Again,
90 to 120.
90 to 110, or if they have memory issues. We'll use high dose pregnenolone levels if they have again that post-finasteride syndrome, or they have like a treatment resistant either anxiety or depression. Okay, we'll use. I'll do 400 of progesterone, 400 of pregnenolone, and we'll do that for about 4 weeks. Usually, we'll start seeing some side effects at that. As long as they're not too sleepy, then progesterone can make them sleepy, and then we'll decrease it, accordingly. One thing that is been on the horizon. I don't know if any of you know anything about brexanolone, which is a synthetic allopregnenolone. It was. Are we still on the CME? Is it on or off? So if it's off, I won't mention. If
you're recording, so
if it's on, I won't mention the company. So it's made by a major pharmaceutical company. It's synthetic allopregnenolone. So you'll remember that chart that I showed you from progesterone to dihydroprogesterone to allopregnenolone. That stimulates GABA. This is a drug that actually takes the place of allopregnenolone and stimulates GABA. So it's a major, has a major calming effect. It's FDA approved for postpartum depression, and it was recently released for major depression in an oral form. The issue with it is there's unfortunately a quirky side effect of sudden loss of consciousness. So without warning. So if you're driving and you're taking this drug, that's not a good thing. So it was originally released for inpatient only intravenous use for postpartum depression. It has about a 7 to 10-fold efficacy versus the traditional SSRIs and SNRIs. I mean, it's great stuff, but it has this quirky side effect. And so the oral form was held up for 4 years. It was released last August 2023 in the oral form, and I thought they may have altered it, but they didn't. It's the exact same as it was, but it has a black box warning on it: no driving or using heavy machinery for 10 hours after taking it. So you take this stuff, you're kind of stuck. So it's a major pathway, and it's physiologic. Unfortunately, it has this side effect. So maybe it can be refined. I don't know. So it's brexanolone is the generic name.
Yeah, I think the lecture on PFS, post-finasteride syndrome, would be very interesting. So if a group here is interested,
well, whenever
you can put that up.
When you need somebody to fill in, he calls on me. So
because the primary care physicians, again, they give him these 5-alpha reductase inhibitors and stuff like that. So I'm not sure how that is impacting everybody. The males, people who have blood pressure, they have whatever, they have prostate problem, they have all these things that they're getting. This
there's three major side effect profiles. One is a genitourinary, they call it, and that's can be erectile dysfunction and anhedonia. So you lose sensitivity in the pelvic area, which is not a fun thing, I guess. The second one, they call it general symptoms. The general symptoms, if you know what you're looking at and read into it, there's symptoms of low testosterone and low thyroid. Those are the symptoms, if you look at the symptom list. And the third one is the mental issues, the one that I showed you with the mental, psychiatric changes. So those are the three sort of major categories. Okay, and I do have some pre-treatment protocols, but quite frankly, these guys are tough as nails, and a lot of them sometimes we get somewhere and they sort of come and go, and I wonder if some of it is it's like social pressures. They all go to the font of complaint. You know what the modern font of complaint is, right? There's a Facebook page for every ailment in the world. So they go to the post-finasteride Facebook page, and it's just complaining. I used to try to answer questions, but I gave up because it's just, there's just no dealing with some of them. So so it's just I don't have 40 hours in a day to be talking to some of the guys are okay. But some of them are just, so again, stay off Facebook. It's not your friend.
There's a website, propitiahelp.ca out of Canada.
Yeah, there's another one, Post-Finasteride Foundation.
Okay.
Yeah, I'm actually listed as a provider on there. Okay. For what that's worth, I don't know. I get phone calls and they want to know what my cure rate is, and when I tell them 0, they hang up. So, it's seemingly. I mean, I worked out all sorts of treatment protocols that should work, and they don't. So I'm not sure exactly. Either I got it wrong, or there's more to it than at least I've uncovered, or. A lot of these guys, it's a good excuse not to have to, they get attention and they don't have to live. So I had a
Is there any timing for the progesterone administration? Because some people say 30 minutes before eating, some people say at night. So is there any timing that could be appropriate for progesterone administration?
I usually do it. If we're doing it once a day, I do it at bedtime because it is sedating.
Right.
Right. If they're severely deficient, or again, they have one of these, finasteride type syndromes, or they have this treatment resistant anxiety and depression, we'll do it up to 4 times a day, 100 milligrams. I don't go any higher. You go any higher than that, Carol?
Yep.
Yeah, I know you do, but
not particularly a finasteride person, but that's interesting. Michael Platt was recommends progesterone at mealtime to help stabilize insulin and glucose responses. Progesterone does help bring up a low glucose.
My wife wants to put me on topical progesterone for my wrinkle. Do you think it'll work?
No.
So
a few times I said no.
GHK copper actually works nicely.
I've been doing that. I've been doing topical rapamycin as well.
So
now, for anxiety, has anybody tried the sublingual progesterone? I have done that for years, and it looks like a lot of people, women especially, they draw great benefit from it. They can take I do 10 milligrams per ml, and then they take 1 or 2 drops daily. But if they have anxiety, they can go up to 10 drops or whenever, and it works perfectly well.
Yep. Usually does.
I usually use it in the pill form, but that's good.
What?
Well, you know, I've been following Felice Gersh on Instagram, and she's been going on about how if you take progesterone orally, it turns into allopregnenolone. And so it's not really a progesterone you're taking a sedative. What do you think about that?
Well, again, allopregnenolone stimulates GABA production.
It's useful rather than not useful. But I saw a study many years ago, 10 women on oral progesterone, and only one got drowsy, dizzy, and the other 9 did not. They measured allopregnenolone. The one who was dizzy had the most allo.
What was the dose?
I don't remember what the dose was, but it was oral progesterone.
So how much converts into pregnenolone if we do the oral progesterone versus alloprogesterone?
I don't know. That's what they're measuring in the urine, pregnenolone.
Yeah.
Well, what percentage?
Because if it goes several places, we don't know exactly which one is what.
Yeah, exactly.
Okay, somebody asked, do I start testosterone therapy in prostate cancer? Yeah. Again, I showed you that chart there. If they've had chemotherapy or radiation, 3 months, at least 3 months, give them and make sure the PSA is less than 0.1. If it's watchful waiting, whatever the heck they call that, the surveillance, you can start it pretty much at any time. Again, we use probably half doses though. I know what the literature shows, but we still have the lawyers all over the place, wanting to steal your life from you. So try to be a little bit cautious with that. So
what dose?
If they're giving them Lupron,
I usually do like half doses on testosterone. So so if we're doing like a cream, if we're going to do 100 milligrams per gram, I'll start at 25 to 50. And a lot of times that's all they need, especially if they've had cancers and they've lost weight and whatnot, they don't need all that much. So, so they feel okay, they feel good, and they get, pretty good blood levels. So that's works well.
That is if they're not in conventional treatment, because conventional treatment is suppressing the testosterone with Lupron.
I know, but that's why I won the best men's clinic in all of Reno. Right. So okay. I'm not, who's the leader here? I'm not, it's not supposed to be me.
I'm going to sleep. I'm tired.
It's late for you guys, isn't it?
Yeah, it's 10
I
p.m.
think we're getting towards the 2-hour limit, so we could finish.
Good seeing you, Stefan.
All right. Good night, guys.
Good night.
Okay. Good night.
Take care, everybody. Good night, everybody.
Thanks so much.
Thank you all.
Thank you.
Thank you so much. Yes.
Thank you, Dr. Clearfield.
Thanks, Dr. Clearfield. Excellent.
Lecture. Thank you.
Anytime.
Great.
Bye, Shell.
Bye, Shell.
See ya.